You can see here's the drain that we have, and we tunnel it out through a hole, and then it sits at the bedside with a little suction grenade that pulls fluid out. You can see the white drain. Drains are barium impregnated, so you can see where they are, and you can see this drain is here, and it's coming all the way to the tip there. All right, any questions on this case?
I just had one. So how many drains did you put in with the first procedure, like when you first did the cranioplasty?
Good question. 0. The case went so smoothly that I didn't feel the need for a drain. It looked really good. Oh no, I'm sorry. We put one in the external above the flap, just to allow for oozing from the scalp, and because I took that out in the OR. But I didn't put one under because I didn't see the need for it. There was no oozing, and the downside to drains is, drains are a conduit for infection too. So it's, you've got a drain tunneled out the skin a centimeter or 2 away from this flap. So remember, bacteria that, fluid that can go out allows bacteria to go in too. So you're always balancing that. You never want to leave a drain too long, because again, it's a conduit for infection. So, so I elected not to do a sub flap or a subdural drain. I just did a subgaleal drain on top of the flap. Remember also that those flaps, those prostheses, they have lots of holes in them. They're almost like if there's a little bit of oozing, it can actually come out, from the inside to the outside, and the outer drain can pull off of it. But he had an acute clot, so it wasn't going to come through. But good question.
Someone is asking, how long were the drains left in place, and what post-op instructions are given?
The drains are, the instructions are to leave the drains to, they're like a little grenade, and you squeeze them and close them. And so they're fully squeezed, and the negative expansion of the grenade causes the little gentle suction. We usually do half pressure for the grenades, so half suction, and they're left in until the drainage is low. So usually, anything from like 10 to 20 cc's every 8 hours is enough to take it out. But if there's like 50 or 60 or 70 cc's coming out, you generally will leave it another day.
And then I just had a question. I know we always talk about what is bright on a CT scan. So drains also can be.
Drains are bright too. Yep, absolutely.
Awesome.
And that's important, because when you pull a drain, you want to know everything's come out, and so you look at the tip to make sure that it's out. And also, you want to see that there's no foreign body left in.
Yeah. All right.
All right.
Yeah.
Go ahead,
Dr. McCaughan, I just have one more question.
Sure.
Yeah. So he initially presented as confused, but when you operate on, did his mentation go back to normal, or would it be an increased risk of altered mental status?
He's back to normal. He's back to his baseline now. He's awake, and his left arm is functioning. Are you saying like at the time I took him to the OR?
Yeah, by that time.
At the time I took him to the OR, he was confused, and he was hemiparetic with his left arm. He could barely move his left arm. But the following morning, after the re-evacuation, he was fine.
Okay. And so there were no permanent neurological deficits as a result?
Thus far, there's no permanent neurological deficits. He had some mild left arm weakness from his original subdural. But he's back to his baseline right now.
Okay.
Yeah. And that's why we always have to be careful about doing these. It's a cosmetic procedure. He wasn't having syndrome of the Trephind. He just wanted cosmetically to look normal, which is a very legitimate, desire. But there's risk with these things, and you need to remember that. Other thing to remember is that 85-year-old people, 85-year-old patients' brains are not like 45-year-old person's brains. They're much more compliant. Think of it like a wet sponge that's really, really saturated, and you put your finger in the sponge and take your finger out, but the indentation stays in the sponge. That's a really compliant like brain. And so in an 85-year-old, one of the reasons he's at risk for the fluid buildup in the subdural space is his brain's not going to come up and fill that space like a young person would. His brain's going to kind of come up a little bit, but it's not going to fill up like a fully inflated, brain would. And so that's why elderly people tend to have recurrent subdurals, because the brain doesn't fill the space. There's space there. Nature abhors a vacuum. So fluid fills up and it can cause pressure, or oozing can fill up. As opposed to a young person's brain, which fills up and even may tamponade further oozing. That doesn't happen in an elderly person's brain.